So, we are going to talk about Duchenne Muscular Dystrophy. It's also known as pseudo-hypertrophic muscular dystrophy. And if you use your word parts knowledge, hypertrophic, that means big, large, or floppy. Pseudo being false. So their muscles may look large and developed, but the floppy part applies. It's not due to muscular strength that makes them look large. The most severe and most common type of muscular dystrophy in childhood is Duchenne's. It's an X-linked inherited, although 1/3 of cases are not traced back through familial lines. They just occur. 1 in 3,600 male births has the likelihood of having Duchenne's muscular dystrophy. So it's just a visual. These are all the muscle masses that are potentially affected by Duchenne's muscular dystrophy. You'll see it involves the face, the mouth. Very important that you recognize it impacts the muscles surrounding the chest wall and the abdominal muscles. Ultimately, that is what causes their demise. So, a little bit about Duchenne's. Typically onsets between 3 and 7 years. With this, you're going to see progressive muscle weakness. You'll see wasting and contractures as the muscles are no longer able to move and rotate the joints. They'll become somewhat atrophied and pulling those joints into a stiff position. You will see hypertrophic calf muscles in most patients. This means that they're going to have a large, well-defined looking calf muscle. Does not mean that it is a strong muscle. And then as they turn into adolescence, they are really going to have a progressive generalized weakness. And ultimately, they do die, and it's usually due to a respiratory or cardiac failure. Now, this can be diagnosed prenatally as early as 12 weeks, and they'll do this by drawing a blood sample. They can confirm it after birth with an electromyelography, a muscle biopsy, and a serum enzyme measurement. Also helpful is a positive family history and then typical characteristics of the disease. So the clinical manifestations of Duchenne's, you'll see a waddling gait, frequent falls, and a Gower sign. You're going to see lordosis. This is the sway back. Pregnant women typically will develop lordosis towards the end of their pregnancy. You'll see enlarged muscles, especially in the thighs and the upper arms. And then in the later stages of this disease, you're going to see muscular atrophy. You'll see mild to moderate mental impairment. It depends on the age of the onset. And you're going to see obesity. Now, I have some little videos I wanted to show you. I want you to, when you look at these little videos, not only watch them a couple times because they're short, but I want you to look at their gait, look for the Gower sign, but look at their shape of their body. You may see a round belly, but look at their legs. Their legs may look a little larger than you would anticipate for a young child. So just kind of look at their whole appearance as I pull those videos up for you. Here is the Gower sign. This is a very short video. But they're weak. And so they use the ground and their legs to walk themselves back up. All right, so let's go back to this one. Is a waddling gait. It's a little bit longer, but you'll get a good idea. Now look at his legs and look at that belly. He doesn't look well-defined and strong. He looks a little soft. And that's that obesity that is a characteristic. See how he's throwing his legs out? He's using his upper thigh muscle to throw that leg out. And I want you to look at his back when he turns around again, if he does. That's the lordosis. See, his front's kind of hanging out because he doesn't have the muscle control in his belly. And then see how his back is swayed. That's exactly what I wanted you to get a look at. Okay, so let's go back to the slides here. So we have a child who has this. How's it going to be managed? Well, first off, there is no cure. Not necessarily an effective treatment has been established. They may get physical therapy and some occupational therapy to hold on to function for as long as they can, but to also help them with coming up with maintain independence for as long as they can. So some alternative ways to still accomplish the same tasks. So the primary goal is to maintain function in those unaffected muscles as long as possible. You want to keep the child as active as possible. So that's done using range of motion exercises, bracing of the extremities, perhaps bracing of the middle of the back and abdomen. They may need to do surgical releases of contractures as needed. That's where they cut the tendon. Genetic counseling for the family, because 2/3 of cases are genetically passed down. A good nursing diagnosis is activity intolerance for these children. They're going to be fatigued. They're not going to be able to keep up with the typical kid. They still need to be encouraged to do normal activities, typical activities, but you need to come up with ways to assist with activity intolerance. So typically these kids are going to see a multidisciplinary team that will help the child and the family cope with the chronic progressive disease. As it gets closer to the end of the progression, there will be counseling and grief counseling. I'm looking to see if there's anything else that I haven't already addressed. Make sure that the child's getting the appropriate healthcare assistance that he needs. So as his needs increase, is the family member or caregiver at home capable of providing that? Do they need nursing care? Does the family need respite care? That kind of stuff needs to be addressed as the child progresses. And that is all I have for Duchenne's muscular dystrophy. The next topic is autism, and this is it's not necessarily a neurological or a neuromuscular type. It is cognitive. It's considered a pervasive developmental disorder, meaning it can impact different areas. It has several different names, so instead of just being autism anymore, it's an autism spectrum of disorders. So we have the autistic disorder, which is considered one of the worst disorders, most obvious. We have Asperger's, which is the high-functioning but socially inept. Rett's disorder, a childhood disintegrative disorder, and a pervasive developmental disorder that's not otherwise specified. So review these sections. Common theme through all of those types is there's an impairment in social reciprocity, meaning they don't know how to function in social situations. There's communication impairment. They don't necessarily know how to convey their needs or desires. And then they also have some type of a restrictive or repetitive behavior, interests, or activities. So they become very obsessive-compulsive about certain things. For example, we used to have a neighbor child who very intelligent, very active. But he was on the spectrum. He did not get along well with the other children. He would not know how to convey what he wanted. So oftentimes it would result in him having a meltdown or just reaching out and taking what he wanted. And he talked about Blue's Clues. I'm dating myself, but he talked about Blue's Clues as if it was a reality to him. And it was nonstop. He had memorized lines from show after show after show. And that's that repetitive behavior. Like it was an obsession for him. And when he would communicate with you, he would communicate using lines from Blue's Clues. Obviously, I had young children in my home who watched a lot of Blue's Clues. That's how I recognized where that communication pattern was coming from. But it wasn't things that he was thinking up on his own. He was relying on what he had essentially memorized from Blue's Clues. He's done fine through his life. He's a senior in high school this year. Very good grades, but still very socially inept. Still very OCD about things. Doesn't like Blue's Clues so much anymore, but he still has to have a very controlled schedule and environment, or it's very upsetting to him. So, for nursing care, just being aware, being available for the family, knowing that it is a challenge for the caregiver or the family member to deal with a child who looks normal, has been physically developing normal, but things are showing up that aren't fitting. So they're finding that what they thought was going to be the perfect normal child has some oddities that takes a lot of patience and dealing with those. Working with the parents to make sure that they're really pushing early language development so the child can communicate needs. Encouraging lots of social competence. And then being aware of what the child's triggers are, what their boundaries are, what their OCD needs are. So that is all I'm going to share about autism. And if you have any questions, feel free to ask. Thank you.